We're going to turn next to a report released last week by the Kaiser Family Foundation that's sharing early insights from 2 states with Medicaid expansion waivers, and they're testing provisions to engage consumers through things like health accounts and healthy behavior incentives. And I'm pleased to introduce MaryBeth Musumeci, Associate Director at the Program on Medicaid and the Uninsured, to share this work with us today.
Thanks, Catherine, and thank you so much for inviting me to share our report findings with you today. For those of you who aren't familiar with the Kaiser Family Foundation, we are a nonpartisan, nonprofit research and policy analysis organization, and you can find a wealth of health-related information on our website, kff.org. So just to set the stage quickly, for background, I'm sure you're all aware that one thing that the Affordable Care Act did was expand Medicaid to nearly everyone, all non-elderly adults with incomes up to 138% of the poverty level. So it's a little over $16,000 a year. And then that effectively became optional for the states after the Supreme Court ruled on the constitutionality of that provision. So as of today, we have 32 states that have adopted the Medicaid expansion. 25 of those states have done it the traditional way as the law envisioned, and then the 7 states that I've shown on this table here have implemented it through what's called a Section 1115 waiver. So that means that the Centers for Medicare and Medicaid Services have given them permission to test something in a way that they wouldn't otherwise be able to do under federal law. So I'm not going to go through this in any detail, but I just kind of wanted to give you background for the landscape of what these states are doing. You can see on the second row that almost all of them have some kind of premium or monthly contribution component. And then on the third row, several of them also have healthy behavior programs. And those are the 2 types of waiver provisions that I'm going to focus in on today. So there are first an explanation about what health accounts are in the waivers. So we went last summer to Michigan and Indiana and did a number of stakeholder interviews as well as focus groups with beneficiaries, and that is the basis for the findings in our report. And today I'm going to talk about our findings related to health accounts and then healthy behavior programs. So when you hear the term health savings account, traditionally it's something that is linked with a high deductible health plan. People can contribute pre-tax dollars and then use that money towards their high deductible when they're using healthcare services. And Michigan and Indiana both have health accounts as part of their Medicaid expansion waivers, but they don't work exactly like that traditional health savings account model. So one important difference is that contributions are post-tax dollars instead of pre-tax. And in Michigan, what you pay into the account is any premiums and co-payments that you owe. And then there's a third-party vendor that administers the account for the health plans. And the health plans are paid on a capitated rate from the state. They provide services without regard to any deductible, and then those premiums and co-pays go to compensate the health plan as well. And then there's a little bit of a different twist also in Indiana, and I should mention that Indiana's accounts existed before the ACA, so they had done a limited coverage expansion prior to the ACA centered around this health account with a $2,500 deductible model, and so they've brought that forward into their ACA expansion. So again, individuals are contributing their post-tax dollars through premiums to their accounts that are administered by the health plans. And then the state supplements those individual contributions to total up a $2,500 account balance. And that is what's used to pay for the first $2,500 worth of medical services, except that preventive services are not charged against that balance. And then if those funds are exhausted in the year, the plans then are paid on a capitated basis by the state. Another element associated with Indiana's accounts is that each beneficiary has a debit card, and the idea is that they can bring it to their provider for the provider to use at the point of service, and the provider would get reimbursed more quickly than they otherwise would, but it also is at a discounted rate. So now to continue with the background, and I apologize, I'm going to move through this complicated information a little bit quickly, but I want to have time to get to the findings. And this is all detailed in our paper that's on our website if you want more information. But the accounts are linked to healthy behavior programs in both states. So this slide shows you the healthy behavior program in Michigan. And basically the process is the same. There's two steps. You would complete a health risk assessment, and then you would have a doctor's appointment and select a behavior that you wanted to work on. The difference is what reward you get, and that depends on what your income is. So folks with income between 100 to 138% of poverty are people who are paying premiums in Michigan, and so if they complete the Healthy Behavior Program in Michigan, they're eligible to have a 50% reduction in their premiums the following year. People from 0 to 100% of poverty do not pay premiums, and so instead their reward for the Healthy Behavior Program is a $50 gift card. And then both groups are subject to paying co-payments in Michigan, and if they complete the Healthy Behaviors, they can get a 50% reduction in their co-payments to the extent that those co-pays exceed 2% of their income. And this is the most recent data that we were able to find in Michigan. This is from September of 2016, and it shows you the types of behaviors that people who were participating in the Healthy Behavior Program were selecting. So weight loss was the highest at 65%. Others were focusing on chronic condition follow-up, immunizations, and tobacco cessation. Some participants were focusing on just one behavior, while others were choosing multiple behaviors. And then in Indiana, it's also, again, various options for how you get your behavior incentives. So in Indiana, one option is if you pay your premiums into your account on time, you are then eligible to roll over your leftover account funds at the end of the year to go towards your next year's premium, so you can get a discount on your next year's premiums. If you both pay your premiums on time and complete your healthy behaviors in Indiana, you are eligible to double any leftover account fund balance and roll that over to pay towards your next year's premiums. And then finally, the third option in Indiana is even if you don't pay your premiums, if you do complete healthy behaviors in Indiana, you can roll over the amount of account funds that are left over to apply to half of your next year's premiums. So in our case studies in Michigan and Indiana regarding health accounts, we talked to beneficiaries, advocates, and providers, and they uniformly were confused about the health accounts and the statements and how they worked. Providers, in particular community health centers, were saying that they were spending a significant amount of time going over the statements and helping folks try to understand how the accounts worked. And this was true even in Indiana, a state which, as I had mentioned, had been using this health savings account model prior to the HIP 2.0 waiver. So it's not necessarily an intuitive, easy thing for people to understand. Secondly, we heard from some health plans who said that there was an administrative burden associated with the health accounts. In Michigan, there's a third-party vendor that the state requires the health plans to contract with to manage the accounts, and some of the health plans said that they would rather focus on other things like care management for people with chronic conditions who are high utilizers rather than having to focus on the things that were identified in the Michigan waiver and working with the vendor to administer those accounts. And we also heard from providers in Indiana that some of them felt that the account debit card for reimbursement was administratively burdensome. It was hard to operationalize, and even if they could they also didn't like the idea that they were getting reimbursed at a discounted rate, and so they would rather have waited longer and gotten their full reimbursement. And I just put on the bottom of the slide here a couple of the quotes that we heard from our focus groups with people not understanding at all how the debit card works. They thought that they should be able to take the debit card to a pharmacy or something like that and have money on it to buy things. They didn't quite understand that it was to use at the provider's office when they went for a doctor's appointment, and then confusion about the account statements and what those were showing. Moving on to our findings about the healthy behavior incentives. At the time we were talking to people in Michigan and Indiana, this was last summer, and then as I said, the most recent data we were able to get was from September of 2016. And so relatively few people to date had completed the health risk assessment. To be eligible to do that in Michigan, you had to be enrolled in a plan for at least 6 months. And so not everyone had done that yet. But out of those who had been enrolled in a plan at least 6 months as of September, 16% of them had completed the health risk assessment. However, even though a few people were actually starting the process, almost everyone went on to complete the process and identify a behavior. So 99% of people who did the assessment at step 1 went on to select a behavior to address or maintain. And 60% of people chose more than one behavior. And people were earning rewards. The most recent data we were able to get, from the state was as of July. About 86,000 people had earned a gift card. About 39,000 had a 50% reduction in their next year's premiums, and about 23,000 had the copay reduction. At the time of our study, folks in Indiana had not yet been enrolled in a health plan for a year, and so they had not yet had data about the health account rollover funds. Not surprisingly, also beneficiaries and providers didn't seem to know a whole lot about the program, likely because it hadn't been fully implemented with the rewards yet. And then finally, in both states, we heard a lot about things that led us to question whether a deferred benefit is an adequate incentive to participate in a healthy behavior program. People were much more motivated by the idea of getting a gift card that was more immediate and they could take and use for something that they needed right away, as opposed to this idea of getting next year's premiums reduced further away in time. And also some of the formulas are complicated about how you calculate how much money the reduction or the rollover actually would be. In addition, we heard from a lot of people that their health plans were also offering some healthy behavior incentives just through the plan associated with gift cards, and people were very positive about those and seemed motivated by those more immediate and tangible rewards. So finally, just to sum up, there are a lot of issues to watch in the months ahead. One thing is that whether CMS's formal waiver evaluations will show whether elements like the health accounts and the healthy behavior incentives actually change behavior, lead to more efficient service use, and improve health outcomes. Those are things that we weren't able to reach in our survey because it was still so early in the program, and those will be important questions for evaluating these provisions going forward. Second, Michigan has some changes in its waiver that will take effect in 2018 that will make the healthy behavior program even more important because it will change the delivery system for beneficiaries between 100 and 138% of poverty, depending upon whether they've completed their healthy behaviors or not. Next, keeping an eye on the administrative burdens and costs to both states and health plans related to all of the information that they have to track. So these programs require tracking of beneficiary income, whether people are considered medically frail and therefore other program rules apply to them, whether they've completed their healthy behavior program or not. So a lot of information that has to be tracked and also exchanged among different actors, which adds some complexity and cost. We also are waiting to see whether the new administration will approve similar provisions in other states, and it will be important to know whether those states have the necessary data systems and communication systems in place, again, to help with this information exchange among the various stakeholders. And then finally, what changes on the legislative or administrative fund to the Medicaid program more broadly will affect program design and federal funding? It's likely that we will see changes through waivers more quickly than the time that it will take for legislation to go through Congress. It's unclear whether as part of the ACA repeal, the overall Medicaid expansion will be repealed, and that is obviously the basis of these waivers. And then finally, if fundamental changes are made to Medicaid's financing structure and states are left with less money overall, what choices those states will make in structuring their programs going forward. So I will stop there and turn it over to the next speaker.